Bismillahirrahmanirrahim. 2-year-old boy was referred to your office for evaluation of developmental delay. He was born at full term to a 28-year-old gravida to para to woman. The pregnancy was uncomplicated, but delivery was complicated by failure to progress, and he was assisted by vacuum extraction. Apgar's score was 5 at 5 minutes. He was incubated because of poor suckling and lethargy. The child present with developmental delay and obstetric history point to a difficult labor or prolonged labor that was assisted by vacuum extraction. Apgar's score was 5 at 5 minutes, denoting that the infant was exposed to prenatal asphyxia. His mother became concerned about his development around the age of 8 months when he was not able to support his head or sit. He now cannot support his head or sit, and he has coos but cannot say any words. So his developmental history, he is 2 years old now, and the mother started to seek the medical advice around the age of 8 months when she noticed that her infant was delayed because at this age of 8 months he was still unable to support his head or sit. Until now he cannot support his head or sit. Concerning his family history, he has an elder sister aged 5 years. She is healthy and is not suffering from any illness. General examination, his weight and head circumference are below the 5th percentile. Neurological examination, he is alert. The language is coos. Cranial nerve examination, his pupils are equal, round and reactive to light. He is not able to fix or follow object. That is denoting that he has visual impairment. His face is symmetric, denoting that the facial nerve is intact. He has dysphagia and frequent choking during feeding with exaggerated gag reflex. These point to pseudobulbar palsy. His tongue is in the middle line without any fasciculation. If you look at this picture, I think you can see the infant has fisted hands. He has scissoring. There is muscle wasting, spasticity, decreased spontaneous movement with limb movement only within the gravity. That is grade 2 muscle power. On examining the deep reflexes, he has exaggerated deep reflexes with clonus, and the plantar reflex was showed positive Babinski sign. Can we summarize the case? The complaint is developmental delay, mainly in the form of delayed head support and delayed sitting. This is a motor complaint, delayed head support and delayed sitting. The onset is since the early months of life. He was not normal before. The mother started to seek the medical advice around the age of 8 months. The obstetric history was positive for assisted vaginal delivery, low Apgar score, and the infant was incubated because of poor suckling and lethargy, denoting that he has hypoxic ischemic encephalopathy. Developmental history, he had developmental delay, and the family history was negative. His sister is healthy and not suffering from any illness. On examination, we found that the motor system is abnormal in the form of fisted hand, scissoring, muscle wasting, spasticity, grade 2 muscle power. The deep reflexes were exaggerated with clonus, and the superficial reflexes show a positive Babinski sign. So, what is your diagnosis? Spastic cerebral palsy, mainly a post-anoxic spastic cerebral palsy. Cerebral palsy is a motor disorder of the developing brain. بالعربي كلمة cerebral palsy تعني الشلل الدماغي. So cerebral palsy is a cause for motor disability. cerebral palsy أحد أسباب الإعاقة الحركية. definition بتاع cerebral palsy it is a non-progressive, a non-familial, permanent motor disorder of the developing brain due to a previous brain insult that has affected the motor areas of the developing brain. What do we mean by a motor disorder? That it is a disorder of either posture, involuntary movement, muscle tone, muscle power, muscle bulk, abnormal stance, abnormal gait, or abnormal coordination. Definition of cerebral palsy. Cerebral palsy is a diagnostic term used to describe a group of non-progressive permanent motor disorder affecting the muscle power, the muscle tone, the movement, the coordination or posture due to a previous brain insult that has occurred during the early brain growth from conception to 3 years of age. Sometimes cerebral palsy is also called Little disease because Professor William Little was the first to describe cerebral palsy. Cerebral palsy is a motor disorder, but the child with cerebral palsy may also have disorder of other cerebral function, mainly in the form of intellectual disability, maybe epilepsy, visual impairment, squint, maybe hearing impairment, delayed speech. The child with cerebral palsy may also have some behavioral difficulty or maybe having feeding problem. لذلك أي طفل cerebral palsy المفروض إنه هو يبقى routinely screened for intellectual disability, for visual impairment or hearing impairment or language delay, and also we should search for the presence of epilepsy. This associated condition may occur in children with cerebral palsy. Etiology of cerebral palsy. Cerebral palsy occurs as a result of a previous brain insult that has affected the motor areas of the developing brain. So the etiology of cerebral palsy is either due to prenatal brain insult, natal or postnatal brain insult. Prenatal brain insult, congenital infection, accidental exposure to irradiation during pregnancy may cause a prenatal brain insult, prenatal asphyxia or trauma, also placental insufficiency due to either antepartum hemorrhage or eclampsia, congenital CNS malformation, and primary microcephaly. All these causes may result in a prenatal brain insult and may be a cause for cerebral palsy. Perinatal and natal brain insult as a cause of cerebral palsy. The extreme prematurity is known to cause cerebral palsy. The extremely preterm infant usually will develop a type of cerebral palsy called diplegia of prematurity or diplegic spastic cerebral palsy of prematurity. Prenatal asphyxia is a major risk factor for spastic type of cerebral palsy. Intracranial hemorrhage, birth injury, neonatal sepsis and neonatal meningoencephalitis may be followed by a spastic type of cerebral palsy as a sequelae of meningitis or encephalitis during the neonatal period. Prolonged hypoglycemia may be a risk factor for cerebral palsy. Also, kernicterus is known to cause extrapyramidal type of cerebral palsy. Extreme prematurity has caused somewhat increase in the prevalence of cerebral palsy in the well-developed country because of the enhanced survival of premature infant weighing less than 1 kilogram. They will usually develop cerebral palsy at a rate of approximately 15 per 100. The major lesions that contribute to cerebral palsy in preterm infant are intracerebral hemorrhage, mainly intraventricular hemorrhage, and also preventricular leukomalacia, and this insult usually will cause a type of cerebral palsy called diplegic cerebral palsy of prematurity. Postnatal brain insults. Cerebral palsy may occur as a complication of previous sinus infection, mainly encephalitis, may also occur following traumatic brain injury and following hypoxia. Hemiplegic spastic cerebral palsy may occur following a stroke. Cerebral palsy is a disorder of movement and posture due to non-progressive lesion of the motor pathway in the developing brain. Clinical expression may change over time as the brain matures. Early manifestations of cerebral palsy are poor suckling, irritability, increased or decreased muscle tone, and abnormal reflexes. The main manifestations of cerebral palsy are delayed motor development, usually in the form of delayed head support, delayed sitting, delayed walking, but also children with cerebral palsy may have abnormal motor development in the form of stiffness of his body in a spastic type of cerebral palsy and hypotonia in a tonic type of cerebral palsy. Early handedness before the age of 1 year may be an early sign of hemiplegic cerebral palsy. Normal children usually develop handedness around the age of 1.5 years or 2 years of age. Very early neck support before the age of 3 months and persistent to walking are early signs of spastic cerebral palsy. Persistent hand clenching after the age of 3 months is also an alarming sign that the child may have cerebral palsy. Persistent primitive reflexes, the tonic neck reflex, Moro reflex, and grasp reflex beyond their normal age of disappearance, denoting that the child is having a persistent cerebral insult. The absence of the normal development of the protective cortical reflex is also an alarming sign that the child is having cerebral palsy. The presence of involuntary movement like tremors, chorea, dystonia, and acidosis, also denoting the abnormal motor development in the child, as in children with extrapyramidal cerebral. Primitive reflexes are normally present in full-term newborn infant, and normally they will disappear with the normal development of the brain. Grasp reflex disappear around the age of 3 months, while Moro reflex and asymmetric tonic neck reflex usually disappear around the age of 4 to 6 months. Children with cerebral palsy may have persistent primitive reflexes. Children should be referred for evaluation of cerebral palsy if they have persistent fisted hand after the age of 3 or 4 months, persistent head lag beyond the age of 4 months, delayed sitting without support beyond the age of 9 months, stiffness or tightness of leg between the age of 6 and 12 months, early handedness before the age of 1 year, and any asymmetry in movement or posture. Cerebral palsy is a motor disorder due to a previous brain insult that has affected the motor areas of the developing brain. The motor areas of the brain are the motor cerebral cortex, responsible for initiation of voluntary motor activity, the basal ganglia or the extrapyramidal system, responsible for controlling the muscle tone and preventing the involuntary movement, and the cerebellum is responsible for coordinating the voluntary motor activity. So, cerebral palsy can occur due to a lesion in the motor cerebral cortex or in the pyramidal trachea, causing a type of cerebral palsy called spastic cerebral palsy. Also, a lesion in the extrapyramidal system or basal ganglia will result in a type of cerebral palsy called extrapyramidal cerebral palsy. Lesion in the cerebellum will result in ataxic type of cerebral palsy. Atonic cerebral palsy is an evolutionary stage in the development of spastic cerebral palsy. The child with atonic cerebral palsy usually will develop spasticity later on and will be a spastic type of CP. Mixed type of cerebral palsy occur when there is a lesion in more than motor areas of the developing brain. For example, a lesion in the motor cerebral cortex and also a lesion in the extrapyramidal system will result in a mixed type of cerebral palsy. So types of cerebral palsy, the major types of cerebral palsy are spastic CP, extrapyramidal, and ataxic cerebral palsy. Spastic cerebral palsy result from a lesion in the motor cerebral cortex or in the descending pyramidal trachea. Extrapyramidal cerebral palsy occur as a result of lesion in the basal ganglia or the extrapyramidal system. Ataxic cerebral palsy occur as a result of a lesion in the cerebellum. The main signs of spastic cerebral palsy are the signs of pyramidal trachea signs, and the main signs of extrapyramidal cerebral palsy are the extrapyramidal signs, and ataxic cerebral palsy, the signs are the manifestation or signs of cerebellar ataxia. So, spastic cerebral palsy will have pyramidal trachea signs mainly in the form of clasp knife spasticity, scissoring of the leg, exaggerated deep tendon reflexes with or without clonus, and positive Babinski signs. While extrapyramidal cerebral palsy, we will find extrapyramidal signs mainly in the form of rigidity, involuntary movement, either tremors, chorea, acetosis, or dystonia. A child with ataxic type of cerebral palsy will have the manifestation of cerebellar ataxia, mainly in the form of incoordination of voluntary motor activity, in the form of dysmetria, ataxic gait, ataxic speech, intention, tremors, nystagmus, hypotonia, and diminished deep tendon reflexes. Spastic cerebral palsy, we will find pyramidal trachea signs or features of upper motor neuron syndrome in the form of clasp knife spasticity, scissoring of the leg, exaggerated deep reflexes, and classification of spastic cerebral palsy depend upon the distribution of abnormal upper motor neuron signs or pyramidal trachea signs. Monoplegic spastic cerebral palsy, only one upper limb is affected and the signs of upper motor neuron lesion are found in only one upper limb. This is uncommon. The monoplegic type of cerebral palsy is rare. Hemiplegic spastic cerebral palsy, one side of the body is only affected and we will find the pyramidal trachea signs in only one side of the body and the other side is healthy. Hemiplegic spastic cerebral palsy usually occur as a sequelae of a previous childhood stroke. Paraplegic spastic cerebral palsy, both lower limbs are affected with signs of pyramidal trachea signs present in only both lower limbs, while the upper limbs are healthy. Triplegic spastic cerebral palsy, when both lower limbs are affected and also one upper limb is affected, that is called triplegic spastic cerebral palsy. Quadriplegic spastic cerebral palsy, the four extremities are equally affected. The diplegic spastic cerebral palsy, the four extremities are affected, but both lower limbs are more affected than upper limb. Diplegic spastic cerebral palsy is commonly reported in children with extreme prematurity and is called diplegia of prematurity. The double hemiplegic spastic cerebral palsy, the four extremities are affected, but both upper limbs are more affected than the lower limb, so it is called double hemiplegic spastic type of cerebral palsy. Spastic quadriplegic, cerebral palsy, double hemiplegic spastic cerebral palsy, and diplegic spastic cerebral palsy. These three types are the most severe form of spastic cerebral palsy because the four extremities are affected, and they are usually associated with intellectual disability, epilepsy, pseudobulbar palsy, and persistence of the primitive reflexes. As we can see, this child, she is having a scissoring of both lower limb, fisted hand, and because of the pseudobulbar palsy, the child is receiving her nutrition through a gastrostomy tube feeding instead of the oral feeding. Spastic hemiplegic cerebral palsy, there is decreased spontaneous movement on the affected side. The mother will notice that the child will have early handedness, preference for one hand over the other at an early age. Handedness is usually established by the age of 3 years in normal developing children. The arm is often more involved than the leg, and difficulty in hand manipulation is obvious by the age of 1 year. Walking is usually delayed, and usually it is a circumduction gait. Associated condition, the child may have focal epilepsy. This is a child with hemiplegic spastic cerebral palsy. We can see that his gait is called a circumduction gait. He has preference for one hand over the other. Spastic quadriplegic cerebral palsy, that is the most severe form of spastic cerebral palsy. The four extremities are affected, and usually the trunk. Usually the child will have also intellectual disability and epilepsy and feeding difficulty due to pseudobulbar palsy, and most children with spastic quadriplegic cerebral palsy are severely handicapped, and most of them cannot walk. We can see in the picture the child is having a scissoring of his leg and muscle wasting. He cannot walk, and even he cannot sit. This is spastic quadriplegic cerebral palsy. The four extremities are affected, and the signs of pyramidal tracheic lesion are present in the four extremities. There is scissoring of both lower limb. There may be also fisted hand or clenched hand. Spastic diplegic cerebral palsy, there is bilateral spasticity of both lower limb. Usually walking is delayed, and there is with normal development of upper limb function. Extrapyramidal cerebral palsy or dyskinetic cerebral palsy, if the involuntary movement are mainly acetosis, it is called acetoid cerebral palsy, or if there is also chorea, it's called chorioacetoid cerebral palsy. Early, the child with extrapyramidal cerebral palsy is hypotonic and have poor head control with marked head lag. Later on, the involuntary movement will be aberrant, mainly in the form of chorea, acetosis, or dystonia, and the muscle tone will change into rigidity. Children with extrapyramidal cerebral palsy may have associated condition in the form of delayed speech, visual, or hearing impairment. On the other hand, epilepsy and intellectual disability are uncommonly reported in children with extrapyramidal cerebral palsy. Mixed cerebral palsy, children with spastic quadriparesis who have evidence of extrapyramidal manifestation, mainly acetosis or chorea, may be classified as having a mixed cerebral palsy. Ataxic cerebral palsy is extremely rare. The child will have the manifestation of cerebellar ataxia, mainly in the form of coordination of voluntary motor activity, as in the form of dysmetria, ataxic gait, ataxic speech, intention tremors, nystagmus, hypotonia, and diminished deep tendon reflexes. Usually, the child may have a mild intellectual disability but no epilepsy. Atonic cerebral palsy, the child will have generalized hypotonia in addition to signs of pyramidal trachea lesion in the form of exaggerated deep tendon reflexes and positive Babinski sign, associated also with intellectual disability. Children with atonic cerebral palsy usually will change into spastic type of cerebral palsy with myelination of the pyramidal trachea. Diagnosis of cerebral palsy is essentially clinical. Key features in the diagnosis of cerebral palsy include motor complaint of a delayed motor development, mainly in the form of delayed head support or delayed sitting or delayed walking. The motor impairment is permanent and non-progressive, so the course is a non-progressive course. The onset of the motor impairment is before the age of 3 years because it is due to an insult in the developing fetal or infant brain. And the motor impairment is not due to a hereditary disorder. The family history must be negative. A positive family history will suggest other etiologies like degenerative brain disease, the presence of epilepsy, intellectual disability, hearing impairment, or language delay indicate that the cause of motor disability is a cerebral cause. Differential diagnosis. Other causes of motor disability or delayed motor development. This could be due to a CNS lesion, either a brain or spinal cord lesion, or could be due to neuromuscular disorder, due to anterior horn cell disease, peripheral nerve, neuromuscular junction, or muscle disorder. Our differential diagnosis include a degenerative brain disease, spinal cord lesion like spinal cord tumor or myelomeningocele. This spinal cord lesion will cause paraplegia usually. Anterior horn cell disease like spinal muscular atrophy or previous poliomyelitis will cause a permanent motor disability. Peripheral neuropathy, whether hereditary or acquired polyneuropathy. Neuromuscular junction disorder like myasthenia gravis, a muscle disease like myopathy or Duchenne muscular dystrophy. All these disorders may cause a motor disability. Cerebral palsy is the most common cause of chronic motor disability that begins in childhood. Our differential diagnosis include CNS disease like degenerative brain disease, which is usually progressive. The onset may occur at any age, and the family history of similar condition is usually present, and usually there is consanguinity between parents. Spinal cord lesion usually will cause paraplegia, either spinal cord tumor or meningomyelocele. Neuromuscular disorder, the child will have no cerebral manifestation, there is no epilepsy or intellectual disability, and usually we will find signs of lower motor neuron lesion, weakness, wasting, and hypotonia. Examples of neuromuscular disorders that may cause motor disability is the spinal muscular atrophy and Duchenne muscular dystrophy. Investigations are needed in children with cerebral palsy in order to detect the etiology of cerebral palsy and also to diagnose associated conditions. We will ask for an MRI brain in order to detect abnormality of the brain structure like cerebral malformation and lesencephaly. We may ask for EEG to detect the epileptic activity in children with epilepsy. And we may ask for auditory brainstem response or visual evoked potential in order to diagnose hearing or visual impairment. Management of cerebral palsy needs a multidisciplinary approach. We need a team of physicians, mainly the pediatric neurologist who will diagnose the case as being cerebral palsy and will start the medical treatment. The child with cerebral palsy needs occupational and physical therapy in order to improve their motor function. He also needs nutritional support and nutritional management in order to improve the feeding, because the child will usually have pseudobulbar palsy. Speech therapy is also needed in order to manage cases of delayed speech. Orthopedic management is needed with development of contracture or complication. Some medications can help management of cerebral palsy. Mainly in spastic cerebral palsy, we can use muscle relaxant to improve the spasticity, mainly in the form of oral diazepam. Baclofen can be also used either as oral baclofen or intrathecal baclofen pump. Botulinum toxin can be injected into the muscle in order to improve the spasticity. In cerebral palsy associated with epilepsy, anti-epileptic medication will be needed in order to prevent recurrence of seizures. Thank you.